Welcome back to Beyond the Mask. Today's episode takes us into the rapidly evolving world of artificial intelligence, what it means for anesthesia providers, and where it might take us next. Joining us is Richard Wilson, no stranger to the podcast, a respected voice in both clinical practice and emerging technologies. He's here to help us unpack the real potential and real concerns surrounding AI in the operating room. Will AI revolutionize perioperative care? Will it enhance decision-making or threaten autonomy? And how can CRNAs and other anesthesia professionals prepare for what's ahead?
CRNA Financial Planning is a sponsor of Beyond the Mask podcast. Investment advice offered through Private Advisor Group. Nothing in this podcast should be construed as investment advice. Plus, did you know listening to our podcast can earn you Class B credits? For details on how to submit, visit the CE credit section at beyondthemaskpodcast.com. Welcome to Beyond the Mask, innovation and opportunities for CRNAs and advanced practice nurses, with certified financial planner Jeremy Stanley and CRNA Sharon Pierce. Jeremy Stanley has worked with CRNAs for more than 23 years, and Sharon Pierce is a former president of the AANA and the NCANA. Join us as we leave the operating room and learn the latest in the CRNA and advanced practice nurse industries. Beyond the Mask starts in 10, 9, 8, 7.
Listeners, I have a surprise for you today. I am joined by a different co-host because Jeremy stood me up. So why don't you introduce yourself, my new co-host today?
Hello, everyone. My name is Larry. I am one of the hosts of Grade 1 View, the resident podcast for future CRNAs by future CRNAs under Beyond the Mask. You may have heard it. If you haven't, you should listen. And I am here today. We are at the AANA Congress here, and I'm super excited to be able to do a co-host with Sharon and do this lovely interview.
And we have the exhibit hall all to ourselves this morning. We have this beautiful glass box basically in the middle of the exhibit hall. We're in the fishbowl here, but normally people are going by licking the glass, sticking out their tongue, doing obscene gestures with their hands.
Too early, though. They can't see us today. We're hiding.
They can't see us this morning. So, Richard, why don't you tell our listeners a little bit about you if they don't know you?
Well, Larry, Sharon, thank you for having me. Glad to be back. Nurse anesthetist, I'm from South Carolina. I've been practicing for about 20 years, been in education for about 16 years now. Assistant program director for the Somnia Nurse Anesthesia program. I do a lot of mentorship also for nurses looking at joining this great field. And just been doing a lot of research on where we're going, right? So we know, Sharon, you've practiced for a while. Larry, you're going to see this as you go into your practices. Where we start is not where we finish. In other words, when we look at the fact of where we're going with technology, where we're going with anesthesia care, it's rapidly evolving. And so we've got to stay on top of that, or else it's just going to leave us.
Well, I know that one of the only drugs that's still around that I started out with, and I can remember when I first got it and we didn't know anything about it, it was this drug called propofol.
Never heard of it.
Well, we had never heard of it. And, one of the places I worked at actually took it off the shelf after it first came in for a political thing. But anyway, that's a whole other podcast. But before we jump into this, I'm going to ask you, Richard, the same question I ask everybody about AI. Should I be scared or excited about AI?
No questions asked, excited.
Okay. I shouldn't be scared at all.
You should not be scared.
Okay, I won't be scared then.
It's hard because of what everyone's saying about it and all these other things, to not be like a little bit nervous of, you know what I mean? Of it, yeah.
I know. I am learning how to love various aspects of it. And I do think, and we'll probably jump into this as we go on down, it's been there for a long time. We just didn't realize that's what it was.
And we don't even realize how we are currently using it already in the operating rooms. And so when I've done some of these talks on AI, and I start mentioning some of the aspects that we're going to talk about later in this podcast, we'll just throw a little tease out there to everybody, is we're currently using this in multiple facets of what we're already doing, and we didn't even realize it.
Right.
And it's really enhanced patient care in some aspects. But if we don't use it properly, then it is scary. And that's the aspect that really we have to think about with AI is if we don't use it properly. No different than when the pulse oximeter came out. No different than when Swan-Ganz catheters came out. If we didn't utilize what we were getting the information from those, we could have harmed patients.
True.
So same thing with AI.
So give us a little bit of history about AI.
So the interesting part is many of us know AI or really think about AI within the last, 5-10 years, as we've seen ChatGPT come out, as we talk about kind of the revolutionary aspect of what AI is doing right now within not just healthcare, but even outside of healthcare, finance. You can look at all the systems out there and see AI. And really, when we think about it, it's been here since the 80s.
Oh, well, the 80s were good to me.
Actually, let me correct that. There was a boom in the 80s. It's been here since the 50s. So you may not remember the 50s, Sharon.
I was close, but
you
I wasn't
may not
there.
remember the 50s. But it started in the 50s, and then it just did not take off.
Well, it started in the 50s because I'm clueless as to what you're alluding to.
Yeah, I don't know.
So it was really just looking at systems. So all AI is micro-learning, right? And they were looking at systems. So they weren't doing anything as complex as deep learning, which you see now with facial recognition and so forth. They were just pulling data points together to really basically mimic what only the human intelligence could do.
Okay.
That's really what they were doing. But nobody bought into it. And it did not really go well, because obviously technology back then was nowhere near what it is now. The support for it, the finances for it, and all of that. In the 80s, there was a big boom for it. So then you started seeing AI used a little bit more. But then again, it died out.
Okay.
To where now AI is basically in everything that we do. It is in a large part of everything we do. I mean, we go facial recognition. We do ChatGPT for just constructing emails or constructing papers, to the microprocess learning that we're seeing in the operating rooms with things like vent modalities and with our cardiac monitoring, and even in intubations, we're seeing some of the AI technology being able to be used.
Mm-hmm.
Yeah. Would you say it's safe to say that when people see AI, because I feel like a lot of people think of AI like ChatGPT and all these other generative things, would you say that there's like a gross misunderstanding overall over like what exactly AI is and kind of what exactly we could and can't use it for? Would you say?
Oh, absolutely. Because a lot of people don't really think about the fact of generative AI versus predictive AI. So we start talking about generative AI, that's where we're looking at the ChatGPT type models, where you're uploading some articles in there and asking it to do an analysis of the articles, right? And create a paper for you based on that analysis. Or we're asking it to create an image for us. We're putting details in there, or create a PowerPoint for us for some of the lecturing. So that's all mostly generative AI. When we start looking at predictive AI, that's when we're starting to get into what we're seeing in the ORs and in the clinical settings and in the hospitals, where it's basically taking a bunch of data points and then saying, hey, what we anticipate may happen out of this is either X, Y, or Z. And you as a human, so getting into what Sharon was kind of bringing up a little bit earlier with autonomy, right, and autonomous aspects of this, we can't give everything over to AI. We still have to analyze, look at the information, look at the data, and know how to still use it to see if that's going to go well, because we're not at that point yet where you can just take your hands off of it.
Mm-hmm.
All right. So let's talk about this predictive AI in the operating room. I'm assuming you're talking about predictive. The biggest thing I've heard about is predicting hypotension.
Yeah. So you got HPI, and I have no conflicts of interest, so I'll put that out there. But when you look at BD or Edwards Life Sciences, they've got the monitors that do hypotension predictive index now, HPI. And basically it's bringing around 5 or 6 different factors in, even analyzing arterial waveform shapes and all the numbers that go with it to say, hey, in about a minute or so, right, you're going to have a 80% or a 90% chance of having a MAP less than 65 millimeters of mercury for your patient. So it's basically predicting it based off all of these factors. It is basing it off studies that when you look at studies talking about acute kidney injury, there are studies out there that show that, I'm healthy. I don't have any renal disease within my system right now. But it's saying that, hey, the studies show that even if I get one hit to my kidney, even healthy, that it sets me up for kidney injury later down the road. And so now they're saying, hey, we've now got to keep our maps up. And therefore, they're using HPI technology, which is, again, AI, bringing all these factors in. And basically, again, using the human intelligence, right? So it's saying that, hey, if I were looking at this, if Richard Wilson was looking at this and he was analyzing this waveform, he was looking at all of the things that go along with what's, the contractility, so the DPDT, when you're looking at the stroke volume and so forth, it's analyzing all of that for us and saying here. So it's doing it in a faster manner than me being able to do all of that individually.
Well, I want to push back on this just a little bit, because if it's predictive, you're still not going to act on it until you see it. How does that truly replace vigilance? Because I'm going to see it.
It never replaces vigilance in my mind.
Right. But just because it's predicting, if let's say it's an 80% chance, I'm not going to treat it until I see it. Now, if I'm vigilant, I'm going to treat it when I see it.
However, it may save you 30 seconds or so in treating the patient because you're now thinking about it. Where if you were just sitting there being vigilant, right, and you were sitting there watching the monitors, you are waiting for it to happen before you think about what are you going to treat it with, how are you going to treat it. And with these numbers too, a lot of when you analyze these numbers is helping you determine, do I need to give an inotrope? Do I need to give a vasopressor? What do I need to give for this patient?
All right, I'm going to push back one more time here.
Of course you are, Sharon.
In Sharon manner.
Because when I was taught and how I teach students is the majority of anesthesia is done in your head before you get there. Okay. So I have already thought these things through. And when I work alone, I already have it ready.
Mm-hmm.
Anyway, I'm one of those where the emergency drugs, everything is back in the left-hand corner. Something happens, I'm ready to go. So I think I'm better than the computer.
Sharon, I've always said you're better than the computer.
In this particular instance, okay.
But here's the thing is, when it starts talking about the predictive part of this, and obviously what we're looking at is, like you said, does it replace vigilance, or why can we not just use vigilance? Well, we also have a different mindset, right? When we're thinking about it is, okay, talking about wanting to treat it. It's a 20% chance that they're going to have a MAP less than 65. You're like, okay, I'm really just going to watch this, right?
Right, and wait for the surgeon to make a decision.
Right, but it's 90% chance you're like, maybe I need to be a little bit more vigilant than I was earlier in just watching it. And in some aspects, you are seeing some people pre-treat. And because they are very accurate, when you look at these monitors and with the accuracy of them, they're like, okay, well then, instead of waiting for it to dip down to 65, I'm going to go ahead and start treating a little bit because, hey, we're nowhere close. I know this never happens in your facility, Sharon, but we got 30 minutes before they make incision, right? After we've intubated a patient.
Sure.
And if you've got a monitor that says, hey, in the next, couple of minutes, you've got a 95% chance of them having hypotension.
Yeah.
You're going to go ahead and treat because you're like, I got no stimulation coming here in just a few minutes. So Again, it's not for every situation, but there are aspects of it that do become very beneficial. But again, it's knowing the technology, knowing what it's doing, and understanding it.
Well, let me rethink this just a moment, because we all do predictive measures. For instance, when somebody's legs are up in lithotomy and, they're going to bring them down and their blood pressure, back in, and I still do it. And, sometimes everything that's old is new again. We used to give them 25 milligrams of ephedrine IM, 25 IV, because, as soon as the legs come down, their blood pressure is going to drop. So that was predictive AI, but it was Sharon predictive AI.
It was just predictive eye.
It was just Sharon prediction, right? So Sharon started all of this. But no, you're right. So what AI does for us, so let's take not just HPI, and we can look at many different aspects, right? What AI is doing for us is taking that knowledge that you're talking about, right? That intuition that you were just talking about and understanding. But it's also pulling numbers from monitors to put like real numbers with it. So we're like, okay, normally we would see this. It's actually giving us real numbers to look at to say, you really have a big chance of this. You can even go back, and maybe this is, something we could talk about, is we even see it in preoperative. So there are areas in the preoperative side where they're pulling information from charts, from EKGs, from studies, all of this information that's in a chart that, we can't read all of that information. We get the big parts of what we want, and it develops risk stratification models. So they can do what is the risk stratification for the patient. You can find that out. And there are companies already out there that have these models, and there are facilities that use them, but they're great for the preoperative side because they just bring in all of that information and say, okay, where I had to spend 30 minutes maybe searching a chart to find all of this out,
sure,
it's doing it in less than 5 minutes.
Interesting. Yesterday we had the hackathon. And that was something that bubbled up out of the hackathon, and they solved for. It was very, very cool. I hate you were not there, Richard. It was incredible.
You scheduled it during the time I had to present.
I know. We're gonna schedule it at a better time going forward. So, what are some of the risks of relying on AI to predict adverse events like hypoxia and hypotension?
So some of the risks are not understanding the system being used, right? So as we see AI boom, and we're going to see it just expand here over the next probably 10 years, we're going to see multiple systems come out. So there's going to be 5 systems, and I'm just making that number up, obviously, but there may be 5 systems that do risk stratification, 5 systems that do cardiac monitoring or anything like that. And we need to understand what those systems do so that we can better prepare to know what it's telling us. So if we don't understand what the system is doing and what the aspects of it are, and we haven't tested that out, we haven't looked into the research of it, if we're using it straight up as just a number, and again, not going back to what some of our intuition is and so forth, then it can actually create harm. So that's where, you cannot turn everything over to AI right now. That's where we have to use AI as an enhancement tool for what we're doing in the operating rooms for the care that we're providing. Because, say for an example, it says, yes, you're going to have a 95% chance of hypotension. And then, like you mentioned, but you're 45 seconds from a major incision on your patient, but I treat them with norepinephrine, and that gets their blood pressure up. Well, then shortly after that, they make incision. Now their heart rate and their blood pressure up significantly. Now I've put the patient at risk for myocardial infarction or a myocardial ischemic event. So we have to be able to really still use the data that it's giving us, but also analyze it ourselves to say, is this really what's best for the patient? So when we're not using that, if we're just using it solely on face value, we could create patient harm.
Yeah, that makes sense. So part of me is kind of thinking like you can use it to kind of plan what you're doing as well. Like if you see that pop up, maybe you're not going to change your LR bag. Maybe you're not going to, turn around and draw up some meds at that particular time. You can just say, oh, I'm going to take a look at this monitor for 90 more seconds and, just kind of focus a little bit more on it, kind of give you an idea of like, oh, let me focus on this for a little bit before I do something different.
And other aspect of that is there are actually big push now, right, is POCUS.
Oh, yeah.
Mm-hmm.
And when you look at point of care ultrasound, so there are going to be systems, and I think there are a few out there already, where as you put the probe on the belly or on the airway, it can go ahead and start identifying structures for you and highlighting those structures so that you could say, yes, that is the antrum.
Mm-hmm.
when you're starting to do the point of care ultrasound, especially on these GLP-1 patients, right? It could actually help you identify the antrum and say, yes, that's it. But again, what if there's a little bit of an abnormality within the patient's abdomen, right? What if there's something else going on? So you still have to be able to say, yes, I agree, that's what it is. But it can enhance, again, the time and the efficiency and the accuracy of some things that we're doing.
Are you a resident or CRNA looking to transition into independent practice? Introducing the 1099 CRNA Institute, taught by Beyond the Mask host Jeremy Stanley and Sharon Pierce. This comprehensive educational series provides detailed guidance on business structure, legal and tax implications, and financial management tailored specifically for 1099 CRNAs. Enroll now and earn valuable continuing education credits as you chart a new course in your rewarding career. Remember, that's aana.com/1099 or click the link in the description of today's show.
So can AI do a personalized anesthetic, and what does that look like, and how can that help our patient community?
Big thing coming out, right? Or that we see have been studied over the years, genetics.
Mm.
And when you start thinking of genome therapy, when you start thinking of the genetic involvement in the anesthetic, and I think Edwin Aroki is doing a lot with that aspect of it. But think about the fact that you can do risk stratification, right? And say you've got a program that is designed to take Larry here, for an example, and say, all right, it's going through Larry's chart. It's going through all of his studies. It's pulled all of his information, and it says, Larry's at risk for postoperative pulmonary issues, right? Because of maybe asthma, maybe COPD, whatever it is. Larry looks pretty healthy, so we're just going to make up some Larry stuff here, right?
This is future Larry.
This is 90-year-old Larry. Here's what we're talking about. So we got a long time to that. But no, in all seriousness, when you think about it, it's like, okay, or we see Larry has had a myocardial infarction 2 years ago. So his risk during this case for another myocardial ischemic event may be high. So basically what it can do is you really look at all these aspects of it, and it can do this risk stratification and pull in and say, okay, we've also been programmed with all of these anesthetic meds that can be used. We know all of their mechanism of action. We know their onsets. We know their contraindications. We know the side effects of them. And then it pull all of that together and say, okay, for Larry, I would do a TIVA with these medications. Again, still needs to be checked. Anesthesia provider still needs to think about it. But this also gets us out of the process of everybody gets a tailored, everybody gets the same exact plan. When we do a lot of our general anesthetics in some of these facilities, you may see that everybody gets lidocaine, propofol, rocuronium in induction. They get isoflurane or sevoflurane, and then they get Dilaudid during the case or fentanyl right there. There's really a lot of kind of the same type of stuff. But we also are seeing a lot of differences in our patient population that comes in.
Mm-hmm.
And so this can help tailor a little bit of, well, they've got severe PONV. How do I take care of that? What do I need to do? And in that aspect of it, especially if you're using the latest models, we don't always have the latest literature sitting right in front of us, or we may not have seen it. I do a lot of talks, and when I talk about literature within the research, I see a lot of people's eyes light up like, oh, I haven't seen that one yet. So this can pull from open evidence. This can pull from PubMed. This can pull from all of those resources to also give us some of the latest information that provides great patient care.
Well, I will tell you, I had a student recently, and I came in and the gas machine wouldn't check. She took a picture and put it on ChatGPT. It told her what to do. And whenever I came in, and she said, I couldn't get it to check. And before I let her finish, and I go, oh, it's this, and, I knew what it was.
Yeah.
She goes, that's what ChatGPT told me. It's like, I would never have thought of taking a picture of the gas machine, putting it in there and saying, well, I want this gas machine checked.
That's what we're able to see. I actually had a colleague, a friend of mine, text me the other day and was like, same thing. Sent me a picture and was like, this anesthesia gas machine's not checking out. Well, it was a machine I was not very familiar with. I teach anesthesia gas machines, but it was one that I don't use.
Like one maybe I would know how to use.
Maybe. But it was one I wasn't very familiar with all of the settings on it. So I literally loaded it in ChatGPT, said, explain a fix for this error message, and sent it right back to her. And she was like, okay, we have tried all of that, so it is Biomed that we need to call.
Well, it's Google on steroids.
It's exactly what it is.
For me, because, we're going to New Zealand, and I said, give me a 7-day driving trip from one spot to another. And normally I would have had to research everything.
But some of it also is, so that is one way that people look at it. But the thing with like things that like ChatGPT, if you use them enough, is they learn you.
Oh my God. Have you fed in stuff to ask it questions about you? Jeremy and I did that, and I sent him mine and he sent me his, and he and I have known each other for 25 years, give or take, and we know each other very well. And it was spot on, which was terrifying. This ChatGPT may know me better than my husband does.
Maybe. You may have spent more time with it. Because when you look
that was good.
When you look at the ChatGPT side of it, right? I mean, it's learning you. And so that's why over time it gets better for you. Because it's constantly, so like I use it for.
Marriage should be like that.
Sharon, that's a whole different
learning
episode.
Your partner over the years, right?
Well, it does get better, people. I've been married to Pierce be 43 years.
Pierce, I'm going to apologize already. I'm not trying to get you replaced by ChatGPT. But you think about, how it keeps learning you. And so like when I'm trying to pull up information for my presentations or my lectures or so forth, it is now more accurate with the way I want to present it.
Interesting.
Because of the prompts I've put into it for it to learn who I was and what I like. So it does a lot. It's doing a lot of learning of me, and therefore it gives me what I'm looking for.
Wait, what if it pops up and says, you're really an asshole?
So were you reading it last week?
We digress, but it's been so much fun. Let's get back to AI and anesthesia. How could closed-looped AI systems change the traditional role of anesthesia providers?
So when we start looking at closed-loop systems and you start thinking about treatments, anesthesia providers, you still got to know what you're doing.
Sure.
For me, there's no machine that's going to replace what we're doing, right? We talk about.
Well, we found that out with sedasis.
Yeah, sedasis is one of them. And I mean, just even going to, don't even think anesthesia. I mean, how many times were these automated cars supposed to take over the world, right? But we see issues with them because they may not recognize something or they create an accident or, God forbid, I think there was a story out there a number of years ago, one drove over a cliff. So there's always still got to be the human component. And all AI is really doing is mimicking human intelligence, is what it really is doing. Learning, reasoning, perception. It's doing all of that aspect of it. So when you start looking at closed systems, you talk about treatment with that, it can help with those, right? But we're not there yet.
Well, I've been waiting for a closed system for over 30 years. My daughter has diabetes, and since she was 5, and I don't understand why they haven't figured this out with a closed loop system. So she doesn't have to stick her finger and all that kind of stuff. And she's here, and we were up at 2:00 in the morning because her blood sugar's 50, and still she might be 38 years old, but Mama's got to help get her fixed because her husband's not here, Yeah. So I've been looking for that for a long time.
Yeah, but you talked about like sedasis, right? And what they were doing was basically a closed loop system because it was basically trying to monitor some things, treat the patient, keep them at a sedative level for using these infusions. I think we will get there. I think we will get to a point where we may see mechanisms such as hypotension and being able to recognize hypotension and some other factors, and it may be able to to titrate infusions for you. Sedation, being able to, once we start getting better systems that are monitoring brain waves and brain activity, and being able to pull in data from the monitor on the hemodynamic side, plus analyzing brain waves, brain activity, putting all of that together, being able to then change sedation at that point in time. So I think we'll see some of that coming into play. And who knows, even in our general anesthetics, with being able to titrate ventilators, being able to change ventilator modes and make recommendations on ventilator modes.
That would be very cool.
That would be cool, yeah.
Yeah, the first gas machines that I ever used, all we had was tidal volume, and the big deal was whether we sighed them every hour or not. So all of these young kids that I train come in from a bigger hospital, and I'm like, teach me about these modes, because they know better than I do.
See, and I love ventilation modalities. I do a lot of presentations on those. We could do that forever. I'm doing it with grade 1.
Oh,
I'm recording that with grade 1 coming up soon, so that's a shameless plug.
Okay, for ventilator?
So ventilation modalities,
I need to, I listen to Grade 1 View because it's a great podcast, and I get Class B credits from listening to Grade 1 View. They won't let me get Class B credits for my own podcast.
Pressure control volume guarantee. If you're familiar with pressure control volume guarantee ventilation, it is actually AI.
Yeah, I guess it kind of is. That's what our ventilators like default to, basically. Yeah.
Because it is doing micro learning between breaths, and then it is literally flipping modes to determine what the driving pressure would be to get to specific tidal volumes. And especially if you get out, is analyzing all the data. And if it gets outside of the data points, right, the standard deviation that is set up, it will flip to volume. It will flip to volume control to figure out what needs to be the new driving pressure, and then flip back to pressure control to deliver the breath.
That's cool.
We're already using AI,
and it's like in ways you wouldn't even think that it's doing it. Yeah.
Well, I've already read that there are millions and millions of data points in all of our gas machines.
Mm-hmm.
I don't know where they're storing it.
Think about things they can pull. Think about airway resistance, compliance. Think, with our ventilation modes. Because we got to think about now, when Sharon was in school, which was not very long ago. Before me.
2015, 16.
Yes,
that's it.
No, but
it was amazing. I wasn't even a CRNA yet, and I was AANA president.
There we go. What was it? 2006, I graduated. I did the same thing. You basically had anesthesia gas machines, which means all they did was provide anesthesia gas for you. You had paper charting. Then you had a ventilator that was separate. It was plugged into the machine, don't get me wrong, but the actually bellows of the ventilator was separate from the machine. So you had to make all these changes. You remember, you changed tidal volume, you had to change IDE ratio too, because it automatically changed on you, right? To where we are now in our anesthesia workstations. We still call them AGMs, but they're technically workstations, because now incorporated in all of it is our airway monitoring with compliance resistance, tidal volumes, the peak airway pressures, plateau pressures. You look at the hemodynamic side, it's pulling in all of the aspects of your hemodynamics with heart rate. It actually, even if we design systems that maybe can analyze the EKG while you're doing it. So you bring in all that data points, and then you bring in all the gas side, the gas flow side, isoflurane, nitrous oxide. And don't ask me how anybody uses it, but yeah, it's still there.
I do.
Come on, Sharon.
Oh, only on wake-ups. Only on wake-ups.
No, it does have some great utility, but my students appreciate that.
Not a whole... not a whole anesthetic.
But you think about the gas flows, right? And you think about if we can pull in all of this data point, what does it do for emergence? Because now we're like, okay, well, we see that maybe we need to turn the anesthesia gas off 30 minutes ahead of time instead of 10 minutes ahead of time for this case. And it can help us actually design emergent stuff.
Very cool. Let's talk about AI and the use of scheduling. What's some dangers there?
The dangers with scheduling is manipulation.
Oh, I would think that having a person versus AI would have more capabilities for manipulation, especially if like your girlfriend works there too or something.
But it's the manipulation of the data put into AI. So if you start altering
if that's already,
times,
yes.
right? Because it's not going to be able to go and say, hey, I know Dr. X always takes slower time because of whatever reason, right? So if you're like, hey, I'm not getting all of my block time for a surgeon, that time, they can maybe manipulate the times entered into the machine that's being analyzed.
Interesting.
So that would be with the scheduling part, that's just one thing. I mean, everybody's already pulling schedulings, right? And trying to do it. So there is good utility in it. And I think it can increase efficiency and hold people accountable and help instead of saying, hey, I want to put somebody here and I want to put somebody there and I'll put one at 15 and one at 16 and one at 12. It can figure all of that out for you.
Well, it can make it equitable.
Yes.
But I still think it could be biased.
Very much. Because trash in is trash out.
Okay.
When you talk about computer systems.
That's what I used to tell my daughter about her bums she used to date.
Well, that's true. But you think about it. So that if you have bad data points being entered or bad data points being pulled, you're going to get bad results.
True. All right. So let's talk about AI decision support tools and how they can change high-risk cases, how they're managed and triaged. Let's talk about that.
So again, we get into thinking about support systems as we think about the perioperative side, right, or the preoperative side. Well, we've already got our risk stratification in there. Some things that we may have overlooked in a chart, it's already being brought to us and it's being told to us in developing the plan of care for our patients, and whether we go ahead and start using phenylephrine or do we start using norepinephrine in our patients, right? And it's bringing, again, latest data points. It's bringing latest research studies to help with that. As we start thinking about decision support systems, is in the ventilators. Do I switch ventilator mode or do I stay with the same ventilator mode that I'm using? Or within this mode, what do I need to do if I've got my parameter set that I want to stay with an end-tidal CO2 of 32 to 35? I want a 100% or 95% or higher SpO2. It can then start saying, okay, well, your FiO2 may only need to be 40% instead of you continue to run it at 70%. It may say that this ventilation modality may work better for the patient than this ventilation modality. So it can also help with those type of aspects. And then again, we've talked a little bit about HPI and we talked a little bit about it. They actually not promoting BD and Edwards, again, no conflict of interest, but they've got a new Swan-Ganz catheter that they were telling me about that now where we used to not be able to see right ventricular cardiac output, we can see that now, which is huge, right? We used to have to kind of guess what that was. Now we're starting to see that, which can help us make decisions in the medications we want to use, make decisions, and even with the risk stratification side, in high-risk cases, do we even move forward right now, or do we not even have the patient optimized enough? So we're putting them at a higher risk of complications than if we would just wait 24 hours.
So what kind of guardrails should we have in place that will differentiate between just doing everything that AI says and using your clinical judgment?
The biggest thing is education and understanding. So we cannot get in the groove of just because the hospital system, the facility, whatever it may be, says, hey, we're going to be using this system, that we take it and say, okay, great. I'm going to use this. It says, the reps tell me that it gives me these numbers and it's going to tell me what I need to do. We, as vigilant practitioners, need to, dive into that and understand it a little bit better to make sure we know exactly what it's telling us. No offense to the reps out there, but, they are selling you a product and that's what they do. So they're not going to tell you all of the negatives about it or the hiccups that can happen. So we need to understand how that information is being brought in and utilized in the AI fashion. And then we need to, and nothing will replace in my mind, looking at a patient, looking at a scenario, and looking at what's going on in the procedure in itself. So that AI part of it is not to replace an anesthesia provider, it is to enhance what they're doing and give them another side of looking at some things potentially, or even confirm, hey, what I'm doing is right.
This kind of puts me in the mind of when the BIS monitor first came out. You use it to trend, you use it as a tool, but you don't necessarily rely totally on it. Like you give them some ketamine, that thing goes crazy.
And what happened when people started relying totally on it?
Wonky anesthetics, I'm sure.
Well, everybody started then thinking, well, this monitor's not any good. And you find places that don't even use the BIS monitor at this point in time because of all of that. And you're right, because I had a patient, I'll never forget it, back in 2006 at one of the facilities I was working at. And we were using a BIS monitor, and it went absolutely crazy. And I mean, it went up for a short period of time to like 70. And I was like, there's no way. Nothing has changed with this patient. Right? Now, if I'm reading the monitor, what's the first thing I'm going to do? If I'm just treating the monitor,
right?
I'm pushing a bunch of Versed, and then my patient's not going to wake up for 2 days, potentially, right?
Right.
But I didn't. I was like, just give it a second. And it calmed right back down, and it went back down to where it should have been, and we were fine.
Right.
So it is really, for me, AI is a tool.
Okay. That's a good way of looking at it.
Yeah, it's going to enhance what we're doing. So it's taking us to the next level of care, but it's not replacing the care that we provide because, again, it's pulling data points. But the data point doesn't say, well, they just nicked the aorta.
Right.
The data point doesn't say they hit the pulmonary artery.
Well,
or we had
you hear the
anti-route
from the suction.
Yeah. Right?
Before AI hears it.
Exactly.
You're already up.
Yep. So it's not one of these tools, and this really is what I'm thinking about with it. It's not one of these tools where we're going to be able to walk into an operating room and we're going to be able to say, I put the patient to sleep, I put them on a ventilator, I put them on an anesthesia gas machine. And even if we have things that say, okay, I can titrate vasopressors and based on these data points, and I can do this with ventilation modalities based on these data points, it's not going to be something that we can walk into operating rooms and say, I put them to sleep, I put them on these, I'm going to sit back for a little while, or I'm going to go grab some lunch and come back. It's definitely, we're still going to have to be vigilant, still be on top, and ensuring that the best care is still provided to our patients.
So how is AI being integrated or discussed at school, Larry?
Ooh, that was actually, I was going to talk about that and ask you that as well, because I feel like it's a real slippery slope in regards to kind of what you utilize AI for and when is it appropriate, when is it not appropriate. In my experience, I've utilized it when I'm looking at my patients for the next day, or if I'm doing a case I've never done before, putting in information, demographic about the patients, about the particular case, it giving me kind of information on like anesthetic plan, potential complications, how to address those sort of things. I feel like that's a big reason, that's a big way that I utilize it. I mean, because it's not, of course, meant to replace, Nagelhout, Miller, Barish, all those, textbooks and stuff. But I think it can really help you, especially since we are trainees, we are new providers or going to be new providers. We haven't seen a lot of things. So it's really helpful for us to kind of be able to understand, okay, these are things to particularly look for. This is even like things of how you set up for a case, like, oh, what position might this case be in? Because there's been a lot of times where I'm going in the morning, I'm like, I don't actually know how they're going to even position this case. And, of course, positioning can vastly change your anesthetic depending on what it is. So I feel like that's like a way that I utilize it. And I think other people have utilized it as well.
So the question I got for you, Larry, especially being an educator, have you done handwritten case plans?
Oh, yeah.
So how much time did it save you when you started using AI to help you develop your plan? In the written portion of it, right, that allowed you as a student, as a learner, as a resident, to now focus on studying the material versus to be ready for the next day versus just finding the material in 3 different books.
Oh, a ton. And I feel like you feel like this little sense of guilt, like you're almost cheating sometimes when you're utilizing AI, but really it's not. It's like you're just finding the resources that you're looking for more quickly and being able to utilize it more. And I would say in the beginning, especially when I was doing handwritten ones, it would take 2 hours sometimes. And yeah, it significantly changed it because you can kind of just truncate all the information that you're looking for and be able to actually study it and kind of create, okay, if this happens, this is what I would do. And if this happens, this is what I would do. So the answer, a lot.
Yeah, it does. So I'm all about efficiency and I'm all about doing, some of the right things. And for me, there's a lot about studying that material. But you made a great point, Larry. It's we have to teach our residents the right ways to use it so that there's not guilt, so that there's not misuse of it overall. So we have to do. So actually, our program has actually been considering and looking at modules and creating modules that would be AI focused. So it's really saying, okay, if you're going to be using AI in your scholarly projects, here's the right way to use it so that you're not, one, getting yourself in trouble with using AI and going against school policy, or that you're not plagiarizing anything, and making sure you check it, because not all AI information right now with
correct.
case plans, with scholarly projects is correct. So it's always making sure as you're reading it that you're double checking it.
Yeah. And anytime I'm utilizing it, like academically, you can prompt it to, at least what I like to do is prompt it to pull resources from specific like textbooks and sources that I trust and I know about.
Yep.
That way it's not just randomly pulled, because a lot of times when you're looking at AI, it'll tell you what the source is, and it might be just some random website from somewhere, right? So I think kind of stipulating, okay, I want you to pull real credible sources and text and stuff like that and give me good information.
So the big thing that you're mentioning there too, which is really, really big with any AI models we're using, especially if you're talking about the generative AI like you're talking about, is the prompts are key. The prompts and the
I want a class on
editing
that.
it.
I want a class on that.
That's what we're working on.
Yeah. Well, you let me know. All right. So let's say there's a bad outcome. Who are they going to sue, AI or me?
Well, it depends on the outcome, Sharon. And
It's a bad
And it
outcome.
depends on how you're using the materials. But for me, it'll be both.
How do you sue AI?
The company that created it. So
Woo!
if you're looking at
Oh,
the fact,
this is a whole podcast.
It is an entire podcast in itself. But for me, if I'm looking at it on the legal end, right, if AI is saying they're going to be predictive and they're going to be giving you, so if you're making a decision off information that was not presented very well by the data points you were given on this AI technology, whatever it may be, whether it's cardiac monitoring, whether it's mechanical ventilation, whether it's sedation, whatever else it may be, right? Whether it's POCUS, whether it's intubations, because there's now a system out there that does AI intubations. If you look at those, I think they can be held liable or will be brought into it based on the system they created that gave you the information you made the decision off of. But then I think you also will be held liable because of the decision you made. So, in other words, your attorney needs to be better than theirs.
As always.
That's all.
As always. So as we kind of wrap this up, Richard, what would you like to leave our listeners with?
Something that I've always been trying to kind of push out there now is stay up to date. Where we started practice is not where we will finish practice. So much is coming out, whether it's medications, whether it's technology, whether it's new disease processes, stay on top of that. Do not, especially right now, do not leave everything to AI. There still has to be our vigilance. There still has to be our intuition. AI can serve as a great resource and a great tool to enhance drastically what we're doing. And don't think we need to be scared of it. We need to embrace it. It's coming. Matter of fact, it's already here. And it's going to grow. This is not like it was in the 80s where it came out or in the 80s when it boomed for a little while, and then people kind of got tired of it, right? Or they didn't trust it. And so then it went away. AI is now what people are fighting to have. So we see a lot of companies fighting for systems that include AI technology, and therefore this is not going away. So we need to embrace it, not fight it, but then also start utilizing and understanding how it can enhance patient care, which is what we want to do.
Sure. Well, with that, Richard, thank you for joining us. Thank you for always answering my calls.
Anytime, Sharon.
And thank you for what you're doing for the community, especially the educator community, and educating the future of our profession. And speaking of the future of our profession, thank you, Larry, for getting up early this morning after the party with a purpose last night. That was a lot to ask, but he too stepped up and took my call. So I appreciate that.
Of course, it's great. It was great talking to you, and I think AI is such an interesting topic. So this is a great podcast room to be on.
And with that, it's a wrap. And Jeremy, you are
Fired.
That's it. Thanks for joining us.
Thank you for tuning in to Beyond the Mask. If you enjoy the show and want to help us grow, the best way to support us is simple. Leave a review on your favorite podcast platform, share the show on social media, and tell your friends. Your word of mouth is what keeps us going strong. We're proud to consistently rank in the top 50 medical podcasts nationwide and to be number 1 in the CRNA community. All thanks to listeners like you. Your support helps us stay there, and we couldn't do it without you. We'll see you on the next Beyond the Mask.
This is Jackie Rolls, President of the International Federation of Nurse Anesthetists. I'm inviting you to attend the 15th World Congress for Nurse Anesthetists, May 7th through 9th, 2026 in Brisbane, Australia. I promise you that you will love meeting nurse anesthetists from around the world, attending the multitude of Congress sessions, and exploring the many unique experiences that Brisbane has to offer. Hold a koala bear, feed kangaroos directly from your hand, climb Story Bridge, one of the only 3 climbing bridges in the world, or travel to snorkel the Great Barrier Reef. This is one Congress you do not want to miss. Cheers!